thank you for having me here. It's a pleasure. I have to say that for the last couple of years, I have really enjoyed being part of this community. Thanks to Professor Metcalf, and thanks again to Cherry for inviting me and for having me here. Yeah, so I'm in a little bit of, so I work for the industry. I work for Bayer. As it was mentioned, I'm privileged to lead the development program for stroke for the alpha-2 antiplasmin inhibitor program. And I'm also an intervention radiologist at Guy's and St. Thomas Hospital. So I have been at the delivery end of thrombolysis for, not in the stroke indication, but for other indications like pulmonary embolism or iliofemoral DVTs through catheter-directed lysis and so on. So I'm very well aware of the issues that we face with the current standard of care. And of course, Dr. Campbell did a great job pointing the obvious that stroke is a big killer, is one of the leading causes of death, and with a massive socioeconomic impact, and that we basically need better treatments. And traditionally, we have seen the last few years that, despite the fact that the incidence of stroke is going down in the Western societies and in the big economies, we see the opposite in the low-income countries. We see that because of the westernization of their diets and their way of living, we see actually that stroke rates are going up. They're skyrocketing, actually. So instead of the overall incidence of stroke going down, it actually goes up. And, we have seen a slow sort of response to a slow improvement in the way we're treating stroke. And obviously, there was a Greek guy who seems to be the first who spoke about stroke. Back then it was called apoplexy. It was and that's the word for when you're hit hard with something on the head and you just lose control. And that's probably the first mention of stroke in medical literature. And then after that, there was a Swiss guy who showed that only 2,000 years later that that's probably because of a clot in the brain. And fortunately, after that, things started speeding up a little bit, and then another 300 years later, we had the Portuguese neurologist who managed to visualize the arteries by using the first contrast agent, for example, to see, to actually proving that this is what's going on. And after that, things start speeding up more, and then with the development of CT and MRI, we were able to diagnose those patients and much faster and much more accurately. But of course, when it comes to treatment, it was only until 1995 when we could say that we can actually offer something to these patients, and that was obviously in the form of alteplase and then tenecteplase, and obviously with that landmark study, the NINDS study in '95, that actually paved the way for the approval of this drug. And then tenecteplase, a few years later, came up, and it's only recently that it's finally catching up, and we can say that we see more and more hospitals changing into swapping alteplase for tenecteplase. Because of, we have the data for that. We have the data that it's at least non-inferior. There are studies that show that it actually might be even better. And obviously, it's far more easy to administer tenecteplase. So that makes a big difference to the physicians and then the nursing staff. But of course, it seems that despite this progress that we have seen, there's still, and as Dr. Campbell mentioned earlier, there's still a lot of room for improvement. And we know that tenecteplase and alteplase can only benefit roughly 30 to 40% of the patients. The rest will still have significant limitations or even die despite treatment. And a big part of that is because of hemorrhagic transformation, neurotoxicity that comes with alteplase and tenecteplase and so on. But also access seems to be a big problem, and that's from a survey that was published in 2019 that shows that even despite all these advances in our understanding of stroke and its treatment, there is still a small minority of people who has actually access to thrombolytic therapies. And you see better results, obviously, in Central Europe and Northern Europe, but not so good results in Eastern Europe and Southern Europe. And obviously, that's a reason for concern, and there are many initiatives out there that are trying to address this by better education, better training of doctors, and so on. But we're still struggling a little bit, and we need to find ways to improve on that. Then, like almost 20 years after the introduction, and after that landmark trial that I showed you earlier, we have the Mr. Clean results in 2015 that showed us that actually we can, by mechanically remove these clots from the brain vasculature, we can actually improve dramatically how these patients are doing, and I think Dr. Campbell made a very good summary of that data. But again, even bigger problems now with adoption. And as an interventional radiologist, I remember how terrified we were when we saw the Mr. Clean data, because we were like, who is going to do this? And I'm not a neurointerventional radiologist. A neurointerventional radiologist back in 2015 or 2014, I remember we were like 10 body interventionalists in my department in Oxford. Back then I was in Oxford. And there was only like 2 neurointerventionalists. And we were all very jealous of them because they had no on-call. They had no on-call. They would only come to do maybe like an AVM, or they would come to do like an aneurysm, but that was like, yeah, how often would you get that? And then overnight that changes, and you have to be there every night. So yeah, we're not that jealous. We're not that jealous of them anymore, needless to say. But that meant that you have to go from like an on-call service that is almost non-existent to a 24/7 service, and that has to happen very, very quickly. And again, in some places like in Germany, Netherlands, France, that happened very nicely and very, in a very seamless way. In some other countries, including the UK, sadly, this hasn't happened. And a big reason for that is, it's like, who's going to do this? How are you going to fund this? How are you going to build all this infrastructure that is needed, and so on. But anyway, these are all just point to the same issues that Dr. Campbell mentioned earlier, that we have these 2 big treatment options, IVT thrombolysis and endovascular treatment, and they have big limitations. So the question is, can we do better? And since I have to speak about what we're doing in Bayer and how we are trying to see if we can actually accelerate lysis without the additional use of exogenous TPA, I'm going to focus a little bit more on this. I don't think that this crowd here needs any introduction to the regulatory mechanism of fibrinolysis. I'm not going to try to make myself sound stupid by trying to explain this to you, but I really love the cartoons. I don't know, I really like them. They are from a recent publication, and my simple brain just loves them. But, you know alpha-2 antiplasmin better than me, probably. I mean, it's a protease. It's one of the brakes of the fibrinolysis system synthesized in the liver, and it basically links to fibrin by factor 13 and so on, and inhibits plasmin. I mean, again, you know better than that. But also, and that's a quite recent. On top of these 3 brakes, the PI, the TAFI, the antiplasmin, you might have a new kid on the block, which is the chimease. A chimease, which we recently found that it might be also one of the brakes of the fibrinolytic system. But anyway, we're not going to talk about this. Maybe on another conference we can talk about this. But going back to alpha-2, it seems that alpha-2 is bad news when it comes to elevation of alpha-2 antiplasmin. Seems to be bad news when it comes to thrombosis and in different thrombotic models, and we have seen that in ischemic stroke, we have seen that in pulmonary embolism, and in other vascular beds. And that's not a new story. That's not a new story. I mean, Guy Reed has been probably one of the leaders in this space, has been doing research on this for the last 30 years. We have a number of different models looking on what happens when you have alpha-2 elevation or when you inhibit alpha-2. And when you focus on stroke, it's very interesting to see that you have a very consistent story that tells you that when you have high levels of alpha-2 in those experimental models, that you get bad outcomes. You get, you get worse brain injury, you get more brain swelling, you get worsening of the microvascular thrombosis, and so on. And you see the opposite picture when you inhibit alpha-2. So, and all these effects seem to be modulated by these basic three mechanisms, like the the effect of alpha-2 on the microvascular thrombosis, the effect of alpha-2 on MMP9s, and the blood-brain barrier, and of course the effect on apoptosis. And we have seen data supporting these three mechanisms, but also we have seen epidemiological data. Now, going to patients, we have seen that patients who have elevated alpha-2 levels seem to have a higher risk for stroke, and also seems to have a decreased rate of successful reperfusion after TPA. And when you look into patients with alpha-2 deficiency, and needless to say that these are not very common patients to find in clinical practice, mostly because they don't really manifest with severe bleeding or things like this, and we don't traditionally check for this kind of deficiencies in those patients. So therefore it's very hard to find them, but still there are in the literature cases that show that these patients don't bleed in their brain, which is one of the good things that we saw, and that was like quite encouraging for us to continue with development in this program, but also showed us that but also showed us that that the absence of alpha-2 does not cause any other systematic issues to be of concern, especially affecting the fibrinolytic state. There was a very interesting study that was published almost a month ago from a Dutch group, the RBIN study, which was probably the largest cohort of alpha-2 antiplasmin deficient patients. And this data was first time presented, I think, at the last ISTH, and it was basically, I think it's the only study that has this cohort of 23 patients that show that the more severe the alpha-2 antiplasmin inhibition you have, the more severe the bleeding phenotype, but also you start seeing the plasma generation profiles change significantly. So you can see in the graph here that the higher the inhibition of the alpha-2, the higher the plasma generation, but also very interestingly, you have like a higher thrombin generation at the same time, which is not as it's a spike. It's not sustained, but it's still there, and it's an interesting finding, I think. Safety-wise, this study didn't change our understanding from what I showed earlier about these deficient patients. It sort of confirms, as much as you can confirm with 23 patients, that these patients are relatively, they don't bleed that much without trauma. I mean, they can bleed more after major trauma or surgery or during menorrhagia, but they don't seem to have like catastrophic or major symptomatic intracranial hemorrhages. So it seems like there's something about alpha-2 antiplasmin, and it seems like if you inhibit alpha-2 antiplasmin, you might have a valid mechanism that can support the hypothesis that if you do that, you can maybe help patients who suffer from stroke. But in the last few years, we have tried different things, to try and see how we can, if we inhibit alpha-2, do we actually see these benefits in stroke? And microplasmin was probably one of these first approaches that people try to, evaluate this mechanism, this theory, and basically they, administered microplasmin to basically consume as much all the alpha-2 that you have in your system, and therefore create an artificial environment of deficiency, and see if this has an impact on stroke outcomes. And Vincent et al., they published this study back in 2009, and while they had very good experimental data that showed that by doing this, by infusing microplasmin to these experimental models, you can have better outcomes in stroke, that was not reproduced in their study. there were people that were they were assessing the study, and they were criticizing the study by saying that, okay, you never really reached 100% inhibition of the antiplasmin, and maybe that's why you never really saw these outcomes that you were hoping for. But anyway, the bottom line is that this program has been shut down now. Microplasmin didn't seem to be working in this setting, but it was one of the first attempts. Then you have plasmin administration, again for the same reason. If you infuse plasmin, the theory was that you're gonna lower alpha-2, and that was this is what we saw in some of the preliminary data that was published by other groups, and it was shown that despite the fact that you are actually seeing lower alpha-2 antiplasmin levels by infusing plasmin, and also that you could see dissolution of thrombus by more than 50%, you were seeing a lot of bleeding, and you were seeing quite a few adverse events. So again, this approach with infusing plasmin to inhibit antiplasmin didn't seem to work very well, and at the moment there are no active trials. Another way to inhibit alpha-2 seemed to be by inhibiting the cleaving enzyme. But I mean, as far as I'm concerned, I had a quick look at the literature. I couldn't find any studies or any IPs based on that. But it seemed to be an interesting approach. There are some trials for other indications, but nothing on stroke. So I'll just move ahead, moving to the main topic of discussion for today. So the monoclonal antibodies seem to be the next logical thing to try. So using an antibody to block alpha-2 antiplasmin. And I'm only going to talk about the two commercially tested, if you want, approaches so far, which is what we're doing in Bayer. So basically we have created a fully humanized antibody that it's blocking alpha-2 antiplasmin, preventing this interaction with plasmin, and therefore preventing the inhibition of plasmin. And then you have the TS23 approach, which is the Guy Reed's antibody, and it's the one that's being tested with the sister trial as we speak, which is basically acting a slightly different way. So this is again a humanized antibody that it's blocking, that is directed against the plasmin-antiplasmin complex. Unfortunately, I cannot go into too much detail about the concentrations that we used in phase 1 or the patent and so on. But there are differences in these two antibodies, and I'm trying to explain a little bit about the preclinical data that we have. Sadly, I cannot talk about our preclinical data because they're not published yet. Hopefully they're going to be published soon, hopefully next year. That's not in my controls, unfortunately. But what I'm going to do is I'm going to present you the next best thing, which is the data that we have from the TS23, and which they actually give us a pretty promising story about the this whole mechanism. And what you can see from this work, that's it's basically shows that's a mouse model, and in a pulmonary embolism, and you can basically see that the alpha-2 inhibition alone dissolves thrombi with a potency that seems to be even higher in comparison to TPA without causing significant bleeding. I mean, the red line is the RTPA alone, and the green dot is the TS23. So that's promising data, obviously, and it seems to be translating well in a mice model in stroke. Again, you see that alpha-2 inhibition alone seems to be reducing brain injury, bleeding, and mortality. And you also see a very nice, in the survival curves, a very nice difference between the high dose of alpha-2 antiplasmin inhibitor and the low dose. So, but more interestingly, it seems that this effect is sustained even when you you deliver when you infuse the alpha-2 inhibitor, even at the later stage. I mean, normally when you give TPA in mice after a certain time, then you don't see the effect anymore. But this doesn't seem to be the case with the alpha-2 antiplasmin inhibitor, which is also one of the reasons that gave us some confidence to say, okay, maybe this is also something that could help us with the problem of the short time window we have. Again, and I'm very sorry that I cannot share our PK data from our phase 1 data. This is some data from the Guy Reed's team and their phase 1. And you can see that after its specific dose, and that's the 2.5 mg per kg, you start seeing what really changes is that you start achieving 100% inhibition for a longer duration of time. And you start seeing that the only thing that changes the more you increase the dose is that you start having a longer duration of inhibition. Now, this is a good thing, it's a bad thing, we don't know yet. It might be a good thing because by inhibiting alpha-2 antiplasmin for a longer duration of time, you might give a better chance for the clot to dissolve. But as we all know, in stroke, you're limited by the futile recanalization. I mean, there's only a number of hours that you have to achieve that, and after which you don't really see a benefit because you just don't have any brain left anymore. However, this might not be the case when we're talking about pulmonary embolism, when we're talking about iliofemoral DVTs, for example, where this prolonged duration of inhibition for more than 2 or 3 days can actually be important. 2 minutes, yeah, I'm almost done now. So, sadly, I showed you some data about the TS23. These are a very brief summary, and again, I apologize that I cannot share more details. That's a summary of the tests that we have run and all the preclinical experiments that we have run, and you can see that we have done pulmonary embolism models, DVT models, and quite a few acute ischemic stroke models, and pretty much we have seen what I showed you earlier. I mean, the results are pretty close and pretty convincing at the preclinical level that we have a mechanism that works. Of course, the limitations. I mean, we're all well aware about the big gap and the graveyard that it has, that neuroprotection and thrombolysis field has been for the last 20, 30 years, and how difficult it is to translate those results to actual clinical trials. So we are hopeful, but we want to stay grounded and remember all these things. Safety-wise, yes, again, as with the TS23 model, we didn't have any safety signals, even when you were comparing alpha-2 antiplasmin inhibition with anticoagulants or antithrombotics. Our development program, we finalized our phase 1. We're in the process of recruiting for our phase 2 study, and we are developing our phase 3, our development program for stroke at the moment. This is our phase 2 program, which is it's our proof of concept trial pretty much. And we're looking into how antiplasmin inhibition affects femoral popliteal clots. We thought that that's a good start to show that, okay, the mechanism works, that by inhibiting alpha-2 antiplasmin in a DVT setting can give us recanalization, or at least it can give us a lower volume clot than what we started with. Anyway, hopefully we'll have results from that by the end of next year. Yeah, we spoke about the sister trial that's ongoing. Yeah, I think I'm gonna stop here. There's a big need for new treatments. We have some good preclinical data for alpha-2, but yeah, the jury's out there. We'll find out soon, I guess, if it works or not.